Well, you are all in for a treat because these three doctors are among the leading experts on GLP-1s. I am in awe of their accomplishments, but I'm going to also probe them for all of the answers because, as we know, GLP-1s has suddenly become the medication class that everyone is talking about, right? Like, I can't go to brunch without my friends asking about, like, are you on it? Have you thought about going on it? And what's fascinating to me about that, and Dr. Shepard, I'm going to start with you on this question, is that GLP-1s are not a new drug. Like, they're the hot new thing, but they are definitely not new. So can you talk a little bit about the history of this group of medications and how we got to a place where suddenly everyone in this room knows what a GLP-1 is? Do we have a mic? Yes.
That's very
Technology.
helpful. Do you see how that changes everything? Hi, everybody. This discussion is very, I think, when we think of where we come in medicine. So let's start there, the innovation behind why we do what we do from clinicians, but also from bench research in being able to push the envelope for medications that can help people for more things. And I'm going to give small context to it, and I'm going to actually pass more of the mic to my colleague here on the left because she is the GLP master. But GLPs basically, you know, when patients come to me in the office, it's the same thing. This is new. And I always have to kind of level set and say, it's actually not new. We've been using this for years in diabetics because this is a form of medication that was helping with glucose mobilization and helping with the levels of glucose to get them to not have high sugar. So now that we have known that for years, I also like to add that because it's been around for so long, utilized in a different way, this actually helps patients feel reassured of safety when we think of safety profile, because it's not new. And then on top of that, because of research and innovation, how we're able to take medications and see how it helps patients in another subset was the weight loss factor. So again, using it for diabetics, seeing the impact and benefit of weight loss, and then again, companies having to go back to make it for weight loss. So there's a lot that goes on behind the scenes that I feel is important for patients to know from a safety perspective, from a research perspective, and then also doing the due diligence in bringing it forward for a weight loss category had to be done as well.
Yeah. So Dr. Salas-Whelan, how do these drugs work?
And before I do that, I want to tell everybody that the person that discovered GLP-1 in the body is a woman.
Woohoo!
It's a woman.
Thank you.
And she doesn't get enough credit for it.
She does not, Dr. Svetlana Mokhjov, and she was doing research, and this was in Rockefeller Center, and then eventually she went also to Harvard, and then with two other male physicians, which are the names that we hear the most, but actually it was discovered by a female. So we have a woman to
That's
thank.
like good dinner talk. Did you know that
Yeah,
a GLP?
did you
Trivia
know?
night.
Yeah, I mean, because we need to know her name, Dr. Svetlana Mokhjov. As we know now Ozempic, Wegovy, Mounjaro, we should know her name.
Love that.
But okay, back to the question. So GLP-1 medications are a hormone. It's a hormone that we make in our small intestine, and it's released when the glucose goes up in our blood. And we have receptors, so hormones are messengers, that's what a hormone is. And we have receptors for this hormone in many places in our body and many places that we're just finding out with new effects. But basically, the reason that it was started as a medication for diabetes was because in the pancreas, it stimulates the production of insulin when the glucose is up, right? So, and it only works like that when the sugar is actually high. So that's the reason that we can use it in patients with no diabetes, is because it only works as a diabetes drug if you actually have diabetes. And then in the stomach, in the gut, we have receptors for this hormone and what it does in regards to appetite control. So that was for the development for diabetes, right? Working in the pancreas to produce more insulin. Now, for weight loss, we have receptors in our body, again, as I mentioned, for this hormone, but I like to explain it very easily. So this medication treats or works in the two reasons we eat, humans. We eat for energy, for fuel, right? But we also eat for our reward. So This drug works for both. In regards to the fuel part, what it does, it increases your satiety hormones, so you feel fuller when you start eating. And then it decreases your hunger hormones in between meals. So for the majority of people, they eat 2 small meals a day without feeling hungry. And then we have receptors in the hedonistic eating and drinking area of the brain, and the amygdala, and what it does, it blocks the response of our reward for food or for beverages, right? So we're hearing more about alcohol. So that's how they work.
Thank you. Dr. Sower, you had a book come out earlier this year called The Ozempic Revolution. And define for us the ways in which Ozempic is creating a revolution. What is it changing? Why is it such a disruptive, impactful medication?
Because of these GLP-1 agonist drugs, especially the weekly injectable ones that are so much more efficacious than the earlier versions. And it came the perfect time that the drugs came to be when people were getting on social media and starting to share their journeys. And what these drugs have done is they've started to let people understand that weight is not about willpower and weight gain is about biology. And it is not your fault. And for years, and I see mostly women here, for years we have been sold a narrative that you're doing something wrong. You are not trying hard enough. You are eating too much, you are not exercising enough, fix it, do better. And if you don't deserve to be seen or treated or respected. And so these medications have allowed me to stand on my soapbox, which I've been standing on for years, but people are finally receptive to say, it really wasn't me. Now that I'm on this medication, or my sister, my friend, my mother, I realize that it wasn't about willpower all along, and it was something going on in their body. And so it's given great freedom to both the individual, to society, and even doctors.
Yeah. Dr. Shepard, can you expand on that a little bit? There is so much shame and stigma around even the word obesity. How do you think that mindset is shifting now because of GLP-1s, both for better, but also maybe in some ways for worse?
Yeah, I think when we think of shaming, I always go to, specifically for women, how we are valued, whether that's what we're taught, if you can contextualize that to cultural, religious, political, societal, is we are actually taught as women from a very young age how to minimize and not value our worth. And then the other part of that is a lot of what you do see in weight gain or obesity has to do a lot with the emotional or internal struggle that people are going through, right? And that's also not brought into the category of obesity. It's usually just like black and white. You gained weight, it was your fault. But there's a lot that goes in between that, and if we don't address that, then we're not addressing the actual shame that comes with the journeys that people have with weight loss, weight gain. And usually what we saw in the past, before the revolution of the GLPs, was we were also being given weight loss in, if you do this for 12 weeks, you'll get this. But that was never sustainable. And so again, that also wreaks havoc on the emotional capacity of what people do in that weight loss journey. And then to add to that, the value of women usually has to do with fertility ages. Whether you have kids or not, it doesn't matter. It's assigned to what you are going to give society. And then after that, in midlife, biologically, your body starts to shift as far as how it distributes weight, and a lot to do with hormones. But then the shame came also in a moment where women were like, well, you're kind of done with your fertility years, so kind of go over there, thank you for your service, and you can go over there to dark corner. And their bodies were changing. And so the emotional part of all of this and the shame that comes with it is something that has to be addressed and owned, but also how we embody that between mind and body.
I mean, there is a lot to unpack there. We could have a whole conversation just on that topic, but we've got a lot of ground to cover. And so I want to shift to some of the kind of extended health benefits or expanded health benefits of GLP-1s, because that to me has been the most fascinating thing, is to see all of the conditions and illnesses that GLP-1s are. There's all this great science coming out showing the positive impact. Dr. Salas-Whalen, can you give us a couple of examples of ways in which GLP-1s are improving the overall health of people?
And I just want to remember everybody, because we are seeing improvement in sleep apnea, autoimmune diseases, cardiovascular disease. All the studies that have been done on GLP-1 have been done in patients with type 2 diabetes and patients with obesity, right? So we don't have any data that we're going to see benefits of a GLP-1 medication in somebody who doesn't have obesity. And I'm not talking about weight loss, I'm talking about the other benefits that we're seeing, right? We don't have any data that is actually, if somebody is in a healthy weight, that they're gonna get any extra benefits, right? Because the main concept of all of those metabolic diseases or complications, even dementia, Alzheimer, they all come from the same point of chronic inflammation, right? So it's inflammation that drives the having these other types of diseases beyond the type 2 diabetes, or hyperglycemia also will cause inflammation, insulin resistance. So when we treat those things, the main issue, which is inflammation, then we're gonna see improvement in many other things, right? Even it can go from skin improvement, from your joint improvement, from neurologically. So we are seeing gastric issues, irritable bowel syndrome, right? Autoimmune diseases, psoriasis, because we're decreasing the inflammation that was caused by the high weight or the high visceral fat or the high percentage body fat or the hyperglycemia. So that's why we're seeing other results. So before we start saying, oh, I want to use it, and when somebody says, I'm in a healthy weight, I don't need to lose weight, but I want to get the other benefits, my answer is, show me your body composition. Because if you truly have more muscle mass, low visceral fat, low percentage body fat, you're good. You're already getting all the other benefits that people are getting from a GLP-1.
Yeah, and I'd love, Dr. Soa, for you to expand on that and really explain who is a good candidate for these medications, because I do think there are a lot of women out there who are seeing people in their friend circle getting great results from being on these medications and thinking, maybe I should go on it to lose these stubborn 10, 15 pounds, this midlife menopausal weight gain. Is that realistic?
Oh, that's a loaded question. So I think first, and this actually goes back to the mind work, I think I ask all people, before I even ask for their metrics, to tell me why. What is your why here? And in my book, the third whole section is about navigating your brain. Because if we can't get a handle of that even before we start this journey, what are we doing it for? So I want to know your why, and I tell my patients, you can give me 3 whys, and one of them can be rooted in vanity. And if you can't come up with anything beyond that, then you're not a good candidate, because skinny, turns out, is not actually motivating. And I think most of us will nod our heads when we hear that. You think it is, but it is not. And so beyond that, moving beyond that, so then we have very clear definitions set forth by the FDA about who is a good candidate. If you have type 2 diabetes, not a bad thing when it comes to insurance coverage, because insurance will actually cover these drugs. And then when it comes to BMI, we have pretty clear guidelines. Now, these guidelines are rooted in BMI, which, as we've noted already, is not a full picture. We're cutting out here. How's that? I think that's better. Okay, so BMI is not a full picture, but it's something that we have. It's quick and dirty. So if you have a BMI greater than 30, you fall into a classification of having obesity, and a BMI greater than 27 with something called a comorbidity. So something that might be improved by you losing weight. And that's what we've had to work with. Now, this is expanding, and I think nuanced. When you have a holistic approach to this, we're shifting a little bit who might be eligible. So people who have had incredible pain in their brain for years, with food noise, with alcoholism, with addiction, this medication will be a path forward. But we have to be very careful about who we are using it in. And weight, body composition is very, very important. So you'll catch a lot of people who have a normal BMI, but when you look at their body composition, they will still benefit from these drugs. So body composition, I really think within our specialty of obesity medicine, is becoming the way forward. And we have to understand the additive benefits of these drugs. Now, on the flip side, who's not a good candidate, if you tell me it's just about skinny and vanity, Well, then we've already established that. But anyone who is just using this for thinness, in my opinion, this is not the right path forward. This is a great, great invention. It is a revolutionary tool, but anything that is this revolutionary needs to be treated with respect, and so we have to be careful.
Dr. Salas-Whelan, when we're talking about body composition, what exactly are we referring to, and how do you get tested for that?
So I like to call it the Holy Trinity, and I'm Catholic. But it's the three metrics you need to know from a body composition is your skeletal muscle mass. A skeletal muscle mass is the muscle that you can work, is the muscle that you can build. It's not the muscle in your gut, it's not the muscle in your heart. We cannot build those. A skeletal muscle is what you can build. And muscle, and I love, and this is one of the things that GLP-1 is bringing to us, is teaching us so many things as physicians, and one is putting the attention on muscle, right? Because that's what we're hearing now, like muscle and strength training and the protein, thanks to the GLP-1, because doing body compositions, we saw patients were losing muscle, so okay, now we start working on building muscle. But we have to remember that muscle is an endocrine organ. Muscle produces hormones, and they're called myokines, and these hormones are anti-inflammatory. Muscle mass, 80% of your glucose or your sugar in your blood gets utilized by muscle, gets sucked in by muscle. Muscle burns body fat for energy. So, I mean, you get the most for your buck, is that how you say?
Biggest bang for your buck.
Biggest bang for your buck is concentrating in muscle, because you're gonna reduce your glucose, you're gonna reduce your body fat, and you're gonna reduce inflammation. So that's one of the Holy Trinity. And then the second one is your percentage body fat, which means what percentage of your total body weight is fat. And in women, ideally, we want it below 28%, and in men, below 20%. And then the third metric is visceral fat. Visceral fat is an active tissue, and visceral fat produces pro-inflammatory chemicals, cytokines. So those are the three things that if we improve building muscle, you're reducing inflammation, reducing your risk of diabetes, your percentage body fat, and then your visceral fat. Those are the three things that everybody, and not just people that are going on a GLP-1. That's something, a body composition, everybody should know, because that tells you your health.
So I'd love, Dr. Shepard, for you to build on that and share some of the lifestyle changes that people should be considering to stay healthy overall, but including if they are on a GLP-1. We know no medication is a magic bullet. You still need to make good choices from a lifestyle perspective. So what are some of the areas people need to focus on?
I would say even GLP use or not, I think that's fundamentally where we have missed, even in healthcare, but also in society, is helping people understand what the root cause of things are and what responsibility we all have, right? Everything that she just mentioned is what we have to do as an individual and be responsible for that. So when we think of the Holy Trinity, that really a lot of that is fundamentally, you should trademark it, is on lifestyle. So when we think of muscle mass, so there's two things that can contribute to the decline of it is the GLP use, but also aging and menopause or perimenopause even. And just in an aging perspective, we use 3 to 5% of our muscle mass every decade, right? So this is something that's going to occur. So if you are on a GLP and now it's also contributing to that, we have the responsibility to build that. So resistance training. Resistance training can be a list of different things where you're using something to push against the muscle in order to build it. Your goal is to tell the muscle to build itself and to signal to build itself. Weight training is going to be probably more bang for your buck as far as resistance training. I'm using yours. Is weight training, but that is something as a lifestyle. And if there's anything that anyone doesn't remember today, walk out with, how can I improve resistance training to improve my muscle mass for longevity over time? Just remember that, because our bodies are beautiful machines, and we're really trying to reconstruct the pie graph, if you want to look at it as a pie graph, is if our muscle mass is decreasing with age, that means our fat content is increasing. So we're trying to push back on that. And that's a simple way that you can look at that. Nutrition, to me, is medicine. And if you're asking about your why, is a large part of that is also, what am I also going to take part in agency? Like, what do we all have as individual agency to take care of ourselves individually? Nutrition is a big part of that. There are a lot of factors in society that push against that, like what we see, what's convenient, processed food over processed food. So what are we going to do to change that kind of cycle in our lives? And it's small steps. And that's why fad things don't work, because they want you to do giant things in a small amount of time, and that's not how life goes. So those two things, I think, if you can find ways to weave that into your life, that's where you get sustainability. So even when you do lose weight and come off a GLP, what am I doing to sustain that and maintain that? And those are two important things.
You teed up all the ways in which we are losing muscle mass as we age, and certainly menopause has a big impact on that. Dr. So I know there's been some new research exploring the interaction and connection between hormone therapy and GLP-1s. Can you share what researchers are finding?
Yes, I shared this with Galina last week, and it clearly stuck.
It blew my mind.
So we have a lot of hope about GLP-1s, and we've noted already that a lot of the research is firmly rooted in type 2 diabetes and obesity. But recently we've had a very optimistic study that it's retrospective, so it's looking backwards, but women who are on both HRT, hormone replacement therapy, or MHT, menopause hormone therapy, plus GLP-1s, see about 30% more weight loss than if they are not on hormone replacement therapy. So what does this say? It further adds to this idea that it is not your fault, that this whole thing is about biology. And no matter how much you will yourself to potentially not gain weight or will yourself to not go through perimenopause or menopause, it's coming for most of us.
You can't escape it. Not yet, anyway. There are amazing researchers who are trying to get us out of this.
And so if you are treating one thing, it looks like we'll have benefit by treating both together. And I think that's very, very exciting. I also think we have to be we have to be realistic in this whole process. We cannot use these tools to just stop the clock or reverse the clock and go backwards. We are going to age. That is a privilege. We just have to do it in the best way possible. And that's going to be individual for all of us. So I'm reluctant sometimes to even share that exciting information because I don't want everyone to think, well, okay, so you hit 45 and everyone's going to go on a GLP-1 and everyone's going to need hormone replacement therapy. But if you need it, that's okay.
I think, and I love that you place it that way, because when we think of our reproductive hormones, estrogen, progesterone, and testosterone, and then you have the GLPs as hormones as well, our bodies are like this beautiful neighborhood of hormones. And so they all interact, they all talk to each other. And so when you have a neighbor that's kind of like not doing well, then it kind of like ruins the whole mantra of what everyone's trying to accomplish. So it would only make sense in that research. And I love that research when it came out, because it showed, again, women in that midlife phase. There was so much, they were like, what did I do, or what was my fault? But the hormones were really creating a different neighborhood. So we're trying to get the neighborhood back.
We want a friendly neighborhood. Yes, definitely. Dr. Salas-Will, in your work, you have a new book coming out in January called Weightless, which is basically, all of your experiences working as an obesity medicine specialist. What do you think are like 2 to 3 things wrong that people keep getting wrong about GLP-1s?
I think we pretty much talked about them already, but more that they're new medications that we don't have data on safety in the long term. They're not new drugs. The other one is that they're an easy way out. And I think this is a big misconception of people that are not using the medication, because the people that are on the medication, they know that is not an easy way out. Actually, it involves more work than many were doing even before, right? Because now we're sending them to the gym to pick up the dumbbells, to count their protein, to be accountable, come to their office, do the body composition. It's not easy. So that's another misconception. Another misconception is that you have to stay on them forever. I think every case, and very similar to Dr. Soa, is I want to know the story that brought you to need a GLP-1 medication, right? And that's going to determine the length of the need of the treatment. If you're somebody who you're in midlife or in your 50s, 60s, and you struggle with weight since childhood, most likely you're going to need this medication long term. But if you're somebody that gained weight during pregnancy, hit midlife, then maybe you won't need the medication. And then there's other things that we can guide the patient. Your biggest bet to not need this medication long-term or to need a low dose long-term is how well you're going to maintain your muscle mass. If you lose the muscle, it's very hard to even decrease the dose of the medication. When patients gain muscle, and that's another misconception, that you go on this medication and you're gonna lose 30% or 40% of your muscle mass. That is not true. That is poor guidance on whoever's prescribing this medication. We all have patients that gain muscle during GLP-1 medication. So that's another misconception.
Great. No, those are ones that I hear all the time. So thank you for clearing that up. Dr. Soa, if anyone in the audience today is feeling like, you know what, after this conversation, I think I'm a good candidate for this, how do you go about finding the right doctor, and what is the conversation to have?
Another loaded question. Okay, I think the best place to start is with my obesity medicine colleagues. You can find one at www.abom.org. You can find someone who's potentially local to you, and that's amazing because you can go in person. I think we kind of building on the things that people get wrong, people will say it's the easy way out. It is not the easy way out, but it also shouldn't be hard. And unfortunately, it is hard to often get access to these medications. There is so much misunderstanding in doctors' offices, and they get it wrong, and they'll say, I would like to talk to you about this, and they will say, oh, that drug, it's dangerous. Like, I don't know when you went to medical school, but it's not. So, and so starting with a doctor who's informed is a great place, but if you don't have that near you, then we do have this advent of telehealth companies and places you can go. I do think, though, this misconception that it should be hard, that you should feel sick, that you should feel uninformed, you should feel unsupported. Unfortunately, I hear that from a lot of people who start these drugs because the traditional system is just not set up for that. And so what I'm excited about is this ecosystem of products that are developing around the medications, be it books, be it products. I started a product line for people to minimize side effects, whether it's telehealth solutions that are coming to the table and saying, we didn't want to get into this space before, but now we realize this is fruitful for the individual. And you know, if you don't have a great first experience, it doesn't mean you're not a good candidate or we can't work around it. You just need a little bit more support. So I'm very excited to see what happens.
I want to say that, and I talk about this in my book, and the science and the medicine of obesity is going 120 miles per hour, so fast that we're not having trained doctors going at the same speed, right? So education is going to be, you're going to have to be a very good advocate for yourself and inform yourself. And I think Dr. Soa has her book. I have my book that's going to be published December 30th. It's called Weightless. And really, it's ourselves in that book, right? So for many patients that don't have access to physicians like us, the book really is our care in their hands.
Yeah, and also for access, so Chief Medical Officer of HERS, and at Hims and Hers, we have gone into weight loss. I think one of the things is there are a lot of different communities in telehealth that provide it, but it may not be responsible. And so, you know, I think that one of the things we really value at Hims and Hers is who's in charge of that. So our SVP is someone who has been obesity for over 20 years and has held positions in that society, and understanding the nuance and the research behind it. And also when people come to our platform, we also have people that were like, we're so sorry, you're just not a candidate, based on the intake and taking the time to personalize it and the ability to provide access because of how insurance kind of safeguards, you know, for lack of a better term, the access. So access being available for 24/7 for people to get it and doing it in a very responsible way through telehealth.
Yeah, already so much innovation happening in this space. For our last minute, I'd love to ask each of you, in the next 5 years, what do you think is GLP-1 medicine is going to look like? I'll start with Dr. Shepard.
I think it's going to be, we're going to add a more holistic view to GLP use and how it's good for all body care and being more responsible for women in midlife. I don't think that we have kind of nuanced that, and that's why these studies are very important. But holistic, and then really tailoring to women in midlife.
Dr. Salas-Will.
For me, I mean, this is just the tip of the iceberg, and I think that we are going to, as a society, reach places in our health that were not possible before.
Dr. Soa, since you got all the loaded questions, I'll give you the last word.
Two things. I'm so sorry. I cannot limit it to one. One, my hope is cost comes down. That is the number one thing to make this more accessible. And then two, we have to remember that this isn't a Band-Aid and it's not a cure-all fix. So while we look forward to what it can do for our health, we also have to look right around us and behind us. We have a lot of work to do in changing our food ecosystem, our packaging ecosystem, the environment around us, how we move. And so we have to do all the things still.
All right. Well, thank you, Dr. Soa, Dr. Salaswell, and Dr. Shepard for this incredible conversation.